Oh, okay. Right.
Okay. Super. Okay, so my name is Amira. I'll continue the presentation about the anatomy of the diaphragm. If anything can interrupt in between the session. Okay, I'll go quite fast. But the diaphragm is what is the diaphragm? Diaphragm is the dome fibromuscular sheet that separate the thoracic and also abdominal cavity. So it's the separation. And then what is the main function for the diaphragm? Mainly is for inspiration. But there is other function for the diaphragm such as muscle for abdominal straining where it assists the muscle of the anterolateral abdominal wall to increase the intra-abdominal pressure. So it helps to support the vertebral column during the lifting a heavy object. So seems like lifting in the heavy object and also for the straining, for defecation, also micturition. The other function is thoracoabdominal pump. This one is where when the diaphragm is descend, so it will reduce the intrathoracic pressure. So when intrathoracic pressure is reduced, intra-abdominal pressure is increased. So somehow it will compress the IVC and push the blood upward. Okay. Okay, next, how is the diaphragm? Diaphragm is, what is the shape of the diaphragm? Is a dome shape, which is, it ascend as in a full expiration as high as fourth intercostal space, while the left dome is fifth intercostal space. So the left dome is lower than the right dome. So the shape, as you can see here, it is inverted J if you see from the lateral, and it is if you see from above, it's like a kidney shape where in conformity with oval outline of the body wall, which is indented posteriorly by the vertebral column here. So what is the attachment or origin of the diaphragm? So diaphragm has three part of attachment. So first is at the costal area where it attached to the lower sixth costal margin, as you can see here, lower sixth costal margin. And then at the sternum, it is at the xiphoid process of the sternum. And then if it is at the posterior, you can see from here, it is upper three lumbar vertebra. So you'll see the picture clearer in the next page where I can show the right and left crust. So the crust of the diaphragm, crura, is a strong tendon that attach to anterolateral surface of the bodies of upper lumbar vertebra. So we have right crust and also left crust. Right crust is larger and longer as compared to the left crust, and it attached to the L1 to L3, while left crust is L1 and L2. Okay, crust is a muscle fiber radiate from each crust. They will overlap and pass vertically upward before curving upward into the central tendon. As you can see here, the central tendon. So central tendon is inseparable from the fibrous pericardium is if you see this from the up from the superior. So because they share the same embryology origin. So some of the fiber from the right crust will pass up on the abdominal surface of the fiber on the left crust and surround the esophageal orifice as a sling-like loop. So this is important because the right crust is supplied by the right phrenic nerve, but the one that form the sling around the esophagus towards the left side is supplied by the left phrenic nerve. Next. So arcuate ligament. So arcuate ligament is a tendinous fiber from the medial edge of each crust unite in with one another in front of aorta at the level of T12 in front of the median arcuate ligament. So you can see here. So they are median arcuate ligament. So two crusts unite together forming median arcuate ligament. While lateral to the median arcuate ligament is the medial arcuate ligament. you have to differentiate within the N and also L. So medial arcuate ligament is a thickening actually formed by the thickening of the psoas fascia that the medial arcuate ligament extend from the side of the body of the second lumbar. As you can see from the picture there, from the L2 extend of the body of the second lumbar to the tip of transverse process. It's just a very short tip of the transverse process of the L1. Kalau while the lateral arcuate ligament is extend from the tip of the transverse process of the L1 to the lower border of the 12th rib. Can see the lateral arcuate ligament. Okay. Diaphragm, what is important to remember about diaphragm, it has several opening, but the major opening that we have to memorize is the three large opening, which is the first one is aortic opening. So the aortic opening, as you can see from the picture here, is at the level of the T12. So this is at the midline. Okay, tengah-tengah, dekat right crust and left crust, in between the left crust and right crust. It is actually behind the median arcuate ligament. And some of from the Snells, it mentioned that this is not the true opening, but it's just a gap behind the posterior margin of the diaphragm. So what it transmit the aorta, azygous vein, and also thoracic duct. Okay, so that is the center, as we have to differentiate between the esophageal opening. Next. So it is at the opposite of the T10, which is 2.5 cm to the left and behind the 7 costal cartilage. So like I mentioned just now, the sling already mentioned. And then what it transmit the esophagus, vagus nerve, esophageal artery, which is actually the esophageal branch of the left gastric artery. So the venous drainage from this side pass caudally to the portal system and cranially to the azygous system, and this constitute to the protosystemic anastomosis. Next. So the next opening of the diaphragm is the vena cava opening. So it is at the opposite of the T8. As you can see from the picture here, is it more to the right, which is right. It is in between the right leaf and also the middle leaf of the central tendon. So it transmit the right phrenic nerve and also the IVC. Next. Okay, by the way, okay, never mind. The blood supply of the diaphragm. So mainly the costal margin, lower 5 intercostal and also subcostal artery. The main mass of the fiber arising from the crura is supplied by the right and left phrenic nerve from the abdominal surface branch of the abdominal aorta. So the small blood supply that supply the diaphragm is pericardiophrenac, musculophrenic, superiorphrenic, and this one is just a small contribution to the blood supply of the diaphragm. Next. So innervation of the diaphragm motor solely by the phrenic nerve, which is C3 to C4, but predominantly is C4 lah. Each half supplied by the own phrenic nerve, but like I said just now, the right phrenic nerve is by the right crust is by the right phrenic nerve, but the one that sling on the left side is supplied by the left phrenic nerve. The proprioceptive fiber to the peripheral of the diaphragm is supplied by the lower intercostal nerve, while the proprioception to the fiber to the central tendon is supplied by the phrenic nerve. So on entering the abdominal surface, both nerves divided into anterior, lateral, posterior branch run radially, gives off the branch that enter muscle from below. So proceed with the development or the embryology of the diaphragm. So what is important here? Diaphragm is formed by the four important structure. The first is septum transversum. As you can see, the biggest most here is at the anterior, is septum transversum, and then the two pleuroperitoneal membrane, and then a dorsal mesentery of the esophagus, where the crura develop. So next. So the important about this is in a congenital diaphragmatic hernia. So the most common site of the congenital diaphragmatic hernia is at the lateral, at the pleuroperitoneal canal, which is we call it as a Bosch-Dallek hernia. This is account for 90% of the congenital hernia, and it caused by the failure of fusion of the septum transversum with the pleuroperitoneal membrane. So the opening between the xiphoid and costal margin of diaphragm anterior, it is usually a small hernia. We call it as a Morgagni hernia. And then the next is a esophageal hiatus hernia. Next. So diaphragmatic hernia, which is sliding hernia, that usually happen in adult. So it happen when there is a intra-abdominal portion of the stomach. It is pulled upward to herniate into the intrathoracic above the diaphragm. So we call it as a sliding hernia. The another type of hernia, which is paraesophageal hernia, is where the portion of the stomach is herniated into the intrathoracic. It is not, the OGJ is not pulled up, but the portion of the stomach is pushed upward. This usually is asymptomatic compared to the sliding hernia. Because sliding hernia will have the stomach mucosa and irritation, and then cause GERD, everything. Next. So the last one is the second last is the traumatic diaphragmatic hernia. These are comparatively rare, but and usually happen due to the blunt injury, which is crush injury to the abdomen, to the chest. So the left diaphragm is far more often affected than the right one, because the right is always protected by the liver, and it accompanied by the herniation of the stomach and split into the thoracic cavity. As we can see from the X-ray here, we have to identify that this is actually the stomach that ascend upward. So it is ruptured diaphragmatic hernia. So usually the surgery is to repair the diaphragm, either through the thoracic or from the intra-abdomen. Next. The last one is a hiccup. Hiccup is an involuntary spasmodic contraction of the diaphragm accompanied by approximation of the vocal fold and closure of the glottis of the larynx. It is common condition in normal individual and occur after eating or drinking due to the gastric irritation of the vagus nerve ending. So it might be symptoms of a disease such as peritonitis, pericarditis, uremia, or pleurisy. Next. Okay, finish.